Chair Rob, we are now live on YouTube.
Thank you very much. It is not quite. Wait a second. Okay, it is 9 o'clock, March 28th. It is the Public Employees Benefit Program meeting. I will open the meeting, and can we have roll call, please?
Good morning, everyone. To start roll call, Chair Rob,
Here.
Michelle Kelly,
Present.
Betsy Aiello,
Present.
Jim Barnes,
Here.
April Karin,
Here.
Leslie Biddleston,
Here.
Jennifer McClendon,
Here.
Betsy Strasberg,
Here.
Janelle Woodward,
Here.
and Stacy Weeks is absent for this board meeting. We do have a quorum. Please remember to state your name and speak loudly and clearly for our transcriber. Thank you.
Okay, thank you. We will move on to public comment. Public comment will be taken during this agenda item. No action will be taken on this matter raised under this item unless matters include future agenda items. Do we have anybody online?
We do have a few online. Chair Rob, you want me to do that slide first? Do you want to do those in Carson first?
Let's go to the ones online first, and then we will get the ones in Carson.
I'll do that, Chair Rob, one second. Just gonna need the slide up.
While we're waiting for that, in Carson City, let's start with Carson City. And then public comment in Carson City.
Morning, Mr. Chairman, board members, staff. My name is Margaret Kelly Osborne, and I'm here to thank the board and staff for reinstating reimbursement rates for out-of-state travel, reimbursement for medically required travel. I just wanted to thank the board and everyone for your help and your consideration.
Thank you for participating in these meetings.
My name's Leanne Owner Welch, Leanne, last name B as in boy, ONER-WELCH. I'm a member. This is my husband, Bill. He'll spell that on his testimony. Today, I'm here in follow-up to my presentation or my testimony in January regarding your appeals process. Our appeal involved a non-assigned claim for a medical device covered for those suffering baldness secondary to cancer from chemotherapy. I was seeking an exception to the plan for the actual diagnosis of alopecia totalis, which is a permanent hair loss, an autoimmune condition. So let's think about this. You'll cover it for someone who is suffering cancer, and I would assume that's because society looks at them and treats them a certain way, and they have a lot of emotional things to go through. And baldness is something that we can help them with because they also lose their eyebrows and their eyelashes, and sometimes all the hair in their body. That's called alopecia totalis. You won't cover it for that permanent condition. I just find that unbelievable. I have tried for 1.5 years for this process of submitting the unassigned claim and the appeal. UMR and PEBP have mismanaged the claim, and I'm now convinced that is purposeful. UMR originally adjudicated the claim at 50%, thus acknowledging the medical necessity. I challenged the 50% coverage by phone with UMR because there's no preferred provider for this medical device in your organizations. Your policy says when you don't have a preferred provider, you will cover it at 80%. Within hours, I was called by UMR. The claim had been reversed. The check was in the check run, and I was told to return it or they would seek action against me. I had provided all the elements you wanted for an unassigned claim, medical necessity, the bill, the tax ID number, everything. I thank you for looking into it last January's meeting, but I'm not surprised that yet another excuse was found. I have appealed on the basis of exception to the plan document. UMR and PEBP have had nothing but excuses or ignoring the reason for the appeal. I've heard it's not our job from UMR, and I've heard from PEBP, not our responsibility. And then I even had one where it regurgitated all my information for 6 pages and then said it's not covered by the plan document. I know, I was seeking an exception. I now find that the latest excuse is, after attending this meeting, was no one covers it, so we won't either. I should have known this process would be a farce. I was not going to come to this meeting because I've spent so much emotional energy on this, and really, shouldn't the focus be on the wellness of our daughter and the appropriate, I should be able to consider this organization helping me. That has not been the case. You use the same form letter for all your denials. So I'm kind of convinced the template must say insert new excuse here. I do not believe you have an effective process for appeals based on plan document exception, based on medical necessity and equity. Thank you.
Thank you.
Good morning. For the record, my name is Bill Welch, and I'm here to follow up on my public comments presented at the January 26, 24 PEB board meeting. At that time, I requested this board formally consider a planned benefit exception to the coverage, which would provide the same coverage of medical device for patients suffering from alopecia totalis as is provided to patients who suffer loss of hair from current cancer treatment. As I stated in my public comments on January 26, 24, it is appropriate that cancer patients are provided this coverage and believe patients who suffer from alopecia totalis should receive same benefits to ensure equitable coverage for all PEB enrollees. I'm going to leave a copy of that testimony because I did formally request this board, not staff, to consider that. Instead of the matter being brought to the PEB board as requested, after having been ignored for over a year, we did finally receive a letter from your executive officer denying our specific request for a plan exception to coverage. And I emphasize that, as I pointed out last time, because they went around about non-cover, all the different excuses, but never spoke to the specific request of a plan exception to coverage. But we did receive that letter. And I guess we should be happy that we finally got acknowledged to the specific request that we had submitted. The letter from the PEB executive officer to my wife denying our request for plan benefit exemption to coverage dated February 9, 24, referenced a review performed analyzing plan documents and clinical policies of various health insurance providers, both government and private sectors, and based on this review, our request for plan exception to coverage was denied. This communication of February 9, 2024 also acknowledged not all plans denied coverage. And with that in mind, at this time, I am formally requesting a written copy of that review, data on what % of all plans in Nevada were reviewed, both private and government, to determine denial of our request, a report on all plan benefit exceptions to coverage PEB has approved and what the rationale for those exceptions were, how many times has the PEB benefit plan been modified to ensure equitable benefit coverages for its members, and what the rationale for those plan modifications were. And again, we just heard testimony, and I was going to reference that, but not the specific case. At the January 26th meeting, you made such a plan modification. Your staff has our contact information and address. We look forward to receiving this information in a timely manner. If it is not going to be provided, I request written acknowledgement and the legal rationale for denial. Finally, I have to say, how this matter has been handled by PEB has and continues to be very disappointing. I hope none of you ever have to go through this kind of experience that our families had to go through in the last year and a half. Thank you. I will leave a copy of the letter from your staff, my testimony of 26, where I formally requested this board, not staff, instead of this matter, and the testimony of today so that you have a written list of the information that I'm requesting in writing.
Yeah, I was going to say, that sounds like a public records request that will be handled in a separate matter.
Right. Well, if they would provide me the process for doing that, I will do that, sir.
I think we have everything we need to start that process at this point. If you'll leave it.
And who would be your secretary that I would leave this with?
We will consider that a public records request.
Can I leave it here? Thank you.
Thank you. Next in Carson City.
Oh, good morning, Chairman Rob. I'm Patty Ann Tanucci, and I'm a 12-year state employee. The reason I'm here is I'm deeply concerned by the agenda item 6. Why can't I say agenda today? No. Okay, item 6 informs the board that Carson Tahoe Hospital has the intent to terminate the contract with UNR. Carson Tahoe Hospital recently sent a letter to the PEBP members informing the members that they intend to terminate the contract with UMR. Carson Tahoe Hospital is our local hospital. You have residents in Carson City, Gardnerville, Dayton, Minden, and the surrounding areas that are not going to be able to go to Carson Tahoe Hospital as an in-network provider if they cannot negotiate their contract. If Carson Tahoe Hospital terminates the contract with UMR, you could force us to choose between life-saving measures and our wallet. If I suddenly am going to have a heart attack, I have to think about an out-of-network charge for my local hospital or driving into Reno to get health care. That's ridiculous. This board needs to work with UMR and find out why Carson Tahoe Hospital wants to terminate our contract with our local hospital. While the letter did not specify a contract termination date, I am here today to voice my concern and bring forth this issue to the board. I hope that this board will actively work with Carson Tahoe Hospital and UMR to ensure that the contract concerns will be negotiated and an in-network continuation of care is provided. Do not leave your PEB members and retirees in this area without a local hospital to go to. Thank you.
Thank you. Next in Carson City.
Morning, my name is Michael Allmeyer. I'm a TMCC employee, also a ASME member. I'm here to try and make sure our insurance doesn't go up any more than it has. I am thankful for the insurance. That's one of the reasons why I am working for the state of Nevada. And it's so on a personal note, I'm a kidney pancreas transplant. So therefore, again, back in 2007, thankful for that. But with the price potentially that you're proposing going up, it's going to weigh a lot on the employees that don't make as much. So with that, I would highly, I wouldn't say highly suggest, but make sure there's some other way you guys can come up with, not putting it on the state employees' backs as far as putting for the insurance for medical and whatnot. So that's all I got.
Okay, thank you very much.
Thank you.
Good morning, Chair Rob, Vice Chair Kelly, members, Executive Officer Glover, Kent Irvin, ERVIN, Nevada Faculty Alliance, for the record. We are very concerned about the impact of employee premium increases on our members and our classified employee colleagues. The increases subtract from hard-won cost of living adjustments and are especially hard for lower-paid state employees who already struggle. The 2023-25 biennial budgets for PEB were approved with insufficient funds to cover the cost trends projected by PEB's actuaries. With no recourse for new funding in the second year of the biennium, PEB is now in the position of having to fund the increases either through employee premium increases or by using reserves. When the state deliberately underfunds the second year of the biennium, it should be the policy to use PEB's ample reserves to cover claims, then true up the reserves in the next budget cycle. PEB's reserves as of December 31st, 2023, in the budget report today were 121 million. 7.5 million of that is excess reserves. 42 million is in catastrophic reserves, formerly known as rate stabilization reserves. And 53 million is in the incurred but not reported reserve, which will never be needed unless the state suddenly eliminates employee health care benefits entirely. Using up to 15 million of reserves to cover the entire increases to employee premiums would be reasonable. However, we recognize that PEB has a fiscal goal to keep the so-called mandatory reserves intact. Therefore, NFA does support the 50% mitigation plan on the fifth page of Executive Officer Glover's report for Agenda Item 7, which only uses the excess reserves as reported as of December 31st. That plan at least lessens the impacts for employees. The 50% mitigation plan appears to distribute the available funds more fairly among the 3 plans and 4 tiers than using the ad hoc premium adjustments from fiscal year 2024. For the future, if PEB faces the same situation, which it is likely, policy should be put in place to use reserves to increase the employer contributions, also known as base subsidies, across all 3 plans and the 4 tiers to maintain employee premiums. That preserves the board's policy of equal employer contributions regardless of the employee's choice of plan. Then the next budget cycle could adjust the state appropriation per employee to reset the reserves at a level that anticipates potential needs. We should not be in a position where benefits have to be cut or employee premiums have to be increased in the middle of a biennium. That's just poor fiscal planning and poor business practice. Thank you.
Good morning, board. Thank you for the opportunity to speak today. Tess Opperman here on behalf of the AFSCME retirees. We echo much of what was just said by Kent and our previous speaker. We're deeply concerned by these increases in the rates. We do understand that the excess reserves went to 0 and the need to make accommodations for that, but we are concerned about these increases. Our retirees and active employees are living on fixed incomes and simply cannot afford the additional costs. So we're concerned about that, and we do ask the board to do whatever you can possible to try to limit those increases to their rates. I also do, as you continue to consider the budget, I will reiterate that the AFSCME retirees feel strongly that their HRA benefits need to be increased. Currently, they still get the calculation of $13 per year, or excuse me, $13 per month per year worked. That rate has remained the same since 2013, and we ask that be increased to at least $15 per year, per month per year worked. We've asked that at the legislative body, but as you continue to think about the budget, we want that to be a top priority. So thank you very much for your time, and we look forward to the conversation.
Next public comment, Carson City.
Thank you. Good morning, Chair Rob and fellow committee members. My name for the record is Terry Laird. I'm the Executive Director of the Retired Public Employees of Nevada, RPEN, here in Carson City. We've been around since 1977, and we have close to 7,000 dues-paying members. I echo all the remarks made by Kent and Tess as well. It's alarming to hear that Carson Tahoe Hospital was going to not renew the contract. I'm a recent Medicare participant of 2 years now. And I can tell you, cost keeps going up for all of us, especially retirees on a fixed income. But I can tell you that services are not competing with the costs. I have knee problems that I have to have corrected. And 5 weeks ago, I was told it would take 2 to 3 weeks to get Medicare to approve what I need to have done. And I'm still waiting. 2 to 3 weeks, it's 5 weeks tomorrow since I've heard on this. And my niece aren't getting any better, so I just sympathize with our folks who are on a fixed income. I'm still working, I'm not retired yet, but it's sad to see what's happening to healthcare, and hopefully you folks can do something to alleviate all the issues that you heard from today. Thank you.
Any further public comment in Carson City? Seeing none?
We have about 5 on right now. One moment, I'll get the slide back up. As a reminder, Zoom is used for public comment only. This meeting is streaming live on the PEB YouTube channel if you want to watch the board meeting there. The YouTube link is located on the agenda. For those who have joined for public comment, your name or last 4 digits of your phone number will be announced, and you will be advised you have been unmuted. Please slowly state and spell your name for the record, then proceed with your comments. As a reminder for those on the phone, please press *6 to unmute. Douglas Unger, you have permission to speak. Please slowly state and spell your name for the record.
Doug Unger, D-O-U-G-U-N-G-E-R, President, UNLV Chapter, Nevada Faculty Alliance, and Chair of the Government Affairs Committee. Thank you, Director Rob and the PEB Board, for your service and consideration. Regarding agenda item number 7, we wish to express most strongly that we would be disappointed if rates for 2025 would increase 35% or more for premiums across the PEB plans, which would hurt most state workers with dependents and families. Please note that PEB maintains something in the neighborhood of 120 million or more in other reserves, including catastrophic reserves, in the past considered, quote, rate stabilization reserves. State employees believe that we were assured by executive leaders that there would be a rate stabilization action next fiscal year should a shortfall materialize. After all, it's the governor and his staff who underestimated medical and prescription drug inflation by amounts which look to us a lot like the Medicare inflation underestimates in the 3-card Monte game of the federal budgeting process. We strongly recommend action that draws from the catastrophic or rate stabilization or other reserves to mitigate premiums by 50% in accordance with the graphic presented in the comparison tables in section 7, page 53 of the board packet. We recommend PEB do this with the understanding that it will request of the next biennium budget the restoration of the approximately $7.4 million to those same reserves. Another approach would be to address state contributions for PEB, which dropped from approximately 93% to 91% of the cost per employee. This budget cut percentage is a causal reason why state workers will pay more in premiums next fiscal year. In a job market in which it's still difficult to hire and to retain quality employees across all state agencies, including at our colleges and universities, for the PEB board not to approve drawing from reserves to mitigate rate increases would contribute to extending the understaffing crisis and worker shortages that still plague our state agencies. We ask the PEB board to look to approve the 50% mitigation option that we understand will be one of the possible actions presented by the executive officer. Thank you.
Thank you. Next public comment online, please.
Person with the first name Chip, please slowly state and spell your name for the record if you wish to make public comment. Fernando J, please slowly state and spell your name for the record if you wish to make public comment. Jen C, you have permission to speak. Please slowly state and spell your name if you wish to give public comment. And Rashida, You have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Chair Rob, that looks like they might just be in the lobby, so I don't think they're trying to give public comment. We will have another public comment section at the end of the board meeting at the last agenda item or second last agenda item.
Okay, thank you. We will close agenda item number 2, move on to agenda item number 3. That board disclosure for applicable board meetings and agenda items from the Attorney General's office.
Thank you, Chair Rob. This is Radhika Kanal, Deputy Attorney General for the record. This agenda item is to allow me to make a disclosure regarding conflicts of interest on behalf of the board members who are eligible for PEP benefits. Pursuant to NRS 281A.420, on behalf of the board members who are eligible for PEP benefits or whose families are eligible for PEP benefits, I offer this disclosure that they will be voting on those items that may affect the benefits available to them or their family members. The law does not require abstention from voting merely because the board member or their family member is eligible for PEP benefits. At this time, I invite any member of the board who has any additional disclosure to make it now. Thank you.
Okay, any further disclosures by any board members today? Seeing none, we will close agenda item number 3, move on to agenda number 4. Consent agenda. Consent items will be considered together and acted on in one motion unless items are removed to be considered separately by the board. 4.1, approval of action items or action minutes from the January 26, 2024 PEB board meeting. 4.2, receipt of quarterly staff reports for the period ending December 31, 2023. 4.2.1, Q2 budget report. 4.3, receipt of quarterly vendor reports for the period ending December 31, 2023. 4.3.1, Q2 Sierra Healthcare Options and United Healthcare Plus Network PPO Network. 4.3.2, Q2 United Healthcare Basic Life Insurance. 4.3.3, Q2 Express Scripts Summary Report. Any items that any board member wants pulled to be considered separately? Seeing none, I will entertain a motion for all these items to be considered together.
Motion to approve the consent agenda items in total.
Okay, we have a second.
Jennifer McClendon, I'll second.
Okay, we have a motion and a second. Any further discussion? Seeing none, I'll call for the vote. All those in favor signify by saying aye. All
Aye.
opposed? Motion passes. We'll move on to agenda item number 5. Discussion of possible action regarding a proposed contract with Carum Health Oncology Concierge to maintain a network of national centers of excellence. A portion of this item may be conducted in closed session to allow review and results of the evaluation of the proposal for contract in accordance with NRS 287.04345 subsection 4. Any action on this contract will occur in open session in accordance with NRS 287.04345 section 5. We will close the public meeting at this point, go to closed session, just in case any board members have questions we can review. So we will ask the public to please step out at this point. We'll go to closed session, and before any action will be taken, we will bring the public back for the final vote. So we will close the session. Thank you.
It's cold out.
Thank you.
call the meeting back to order. We are on agenda item 5. I want the record to note that gave the time that we were going to be in closed session. We had quite a few of the public participating before we went into closed session. We came back from closed session and staff did everything they could to find the individuals that were participating in the meeting before we came back into open session. They checked the lobby, they went in the parking lot, checked cars. We've done everything we can to ensure that we're not leaving any of the public out at this point. So we're going to continue with agenda item number 5. And it is for possible action. We did have short discussion. Is there any other discussion before we entertain a motion? Seeing none, I will entertain a motion for agenda item number 5.
It's Michelle Kelly here. I'll make a motion that the board approve the proposed contract with Carrum Health as presented. Yeah.
Okay, we have a motion.
I'll second.
We have a second. Any further discussion by the board? Seeing none, I'll call for the vote. All those in favor signify by saying aye.
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 All those opposed? Motion passes unanimous. We will move on to agenda item number 6, Executive Officer Report. Celestina Glover, Executive Officer, Information and Discussion. 6.1, the wrap document, Centers of Excellence Benefit.
This is Celestina Glover for the record. What you have before you is my executive officer report. Starting off, we recently had the budget kickoff meeting. In that meeting, we discussed timelines, what our requirements are going to be, deadlines for certain requests such as our BDRs or BDRs being bill draft requests. Any technology requests we may have. I put some timelines in the report that are probably most significant to PEB at this point. This is not all of the deadlines and timelines that the budget office gave us. But I just wanted to give you an idea of what we're looking at. Some individuals maybe are involved with budget and seen this, and so they're aware of it. This year, they did separate the meetings. They put the directors in one meeting, so directors and deputy directors. So we got a higher level overview of what is expected for this upcoming budget building cycle. The fiscal staff, so your ASO4s, your chief financial officers, and some of those folks had a separate, more in-depth technical meeting where they were essentially given their marching orders as to what will be expected of them. During the May meeting, we will come back with some ideas of what we would like to include in our budget. The same as we did last go round, last session, we will schedule meetings when we go into session to talk about bill draft request or bills that are pending that may affect PEB, even though it's not necessarily something that PEB is bringing up. We'll ask for direction as far as how you would like us to respond to any bills. And that could be fiscal notes, that could be testimony, whether it's in neutral, for or against. Typically, PEB will stay neutral unless we know that the impact of that bill is really significant to the program in general, whether it's for or against. So we will schedule those meetings as needed. A lot of those meetings will probably be virtual because they may be short notice meetings, but we will make sure that we have enough time to get the agendas posted and we meet our open meeting law in that way. So I just wanted to give you an idea of what was coming up. So that's that portion. We have the Carson Tahoe issue. There is a lot of public comment about that. You've heard public comment here. I've had some discussions with one individual from Carson Tahoe. I've talked to UMR. The network agreement is between UMR and the hospital. We're not privy to those contracts. They are confidential, so we don't know what's in them. Carson Tahoe came to us hoping that we would do something, but we know what they've said their issues are, but their issues are across the book of business. They're not just PEP specific. Obviously, we can't get involved with some other employers' plan. But all we could really do is, listen to what they had to say and simply address the issues and ask them to continue to work with UMR. I know UMR has been having weekly meetings to review those claims and to determine what the problems are, what can be done, what's owed, every aspect of that. Carson Tahoe decided to go ahead and send out the letter to all their patients that come under UMR. So it's not just PEB members, as I said, it's any of their book of business that says they intend to terminate the contract. They didn't give a date. We're hoping the issues will be resolved and that won't happen. We are looking to have a meeting with leadership at Carson Tahoe, and that meeting will include myself, our board chair, Jack Robb, and the UMR staff, along with, as I said, Carson Tahoe leadership. That meeting has been all over the board as to what date, so it keeps moving, but as soon as I have a set meeting and I have something to bring back, I will bring that to the board, hopefully next board meeting, so that I can give you an update as to the results of that meeting if the issues aren't resolved prior to then. Carum Health Benefits wrap document. So I've attached the wrap document. As I said in the previous agenda item, depending on the approval of the contract, we would add the oncology services to the wrap document. It wasn't here originally. They gave us a draft of what they like to see edited and rewrote it essentially to be more in line with PEB's other wrap documents. So we will add the oncology services. It will go in as a general oncology. We won't list probably every single service. It's just something to say, okay, here's the various services you can get by going through this. It is a voluntary option for our members. They do not have to go to Carum if they want to stay with their regular providers for whatever service they're having and go with whatever other providers their provider may refer them to. So, but this gives them another option in the event that they want to seek centers of excellence, oncology through the concierge services. So that's where that document is. I didn't put it as a action item. It's information so that you can see what that document looks like, because all the services are rolled into our master plan documents anyway. We cover all these benefits through our regular plan. This just gives them an option to go to a different provider. So with that, I'll take any questions.
Go ahead.
Leslie Biddleston for the record. You mentioned BDRs, those of us that are state employees are very familiar with BDRs. Is PEB planning on bringing up or doing any of their own BDRs? And if yes, can you give us kind of a outline or what those are?
So this is Celestina Glover for the record. We are reviewing our own statute, so we have 287, to see if there are any changes there that we need to make. I'm working with my staff and I'm trying to determine what the changes are that we should submit. I have a meeting scheduled with the governor's office on, I believe it's the 12th of April. They are doing a review with each of their agencies to look at any BDR requests we may have. Primarily what we're looking at is streamlining 287 to make our processes a little easier. And part of that is around the closed meeting for our RFPs and contract approvals, try to streamline that so we can get through that process quicker. That is our main focus. And then just any language in there that we think needs cleaning up more than anything else.
Thank you.
Okay, we'll go to Miss Aiello and then Miss Kelly.
Betsy Aiello for the record. Most of our public comment that was written did come in regarding the Carson Tahoe issue.
as we all know, the state of Nevada, there in Carson City, the surrounding areas, a lot of state employees. And so it's extremely concerning. I know you said it's just one of the UMR lines of business that feeds into Carson Tahoe, but my guess would be it's a very big line of business. And I'm happy to hear that you and Chair Rob are going to meet with Carson Tahoe. I'm not sure what the meetings are going on with UMR. I'm guessing as our vendor, there would be meetings going on with that. And I'm not sure if there's any entity getting together because someone's having a heart attack, they live in this area, they call an ambulance, they'll get brought to Carson Tahoe very likely. The ambulances aren't gonna say, oh, you're out of network, we're gonna drive you all the way to another area. I mean, I don't know, I'm wondering based on the percentage of state employees in PEB that what leverage we have both with Carson Tahoe or UMR, or I'm guessing there are things that we aren't as privy to that are being done, but I just wanted to go on the record that it's a very concerning issue because I think it could have, if they cut the contract, disastrous outcomes, and I don't even know how that would impact our relationship with UMR and their ability to provide services for our employees. Because I think there's a relationship that they have to have a network that's sufficient to provide for, and I guess it's not my employees, the state's employees.
Okay,
Anyway.
thank you for your comment. Jack Robb for the record. Listen to this conversation, listen to Ms. Glover's update and public comment. I can assure you that I've reached out to multiple members of Carson Tahoe's leadership. And we have a common goal, and that's serving the people of Carson City and state employees. So we have a common goal. We're working towards a resolution. We're going to continue working towards that resolution, everything we can do within our power. Some of us not within our power. There's third-party providers, and there's a hospital. We're one of three legs. So we're going to do everything we can in our power to ensure that we continue to serve the state employees and the people in the Carson Tahoe.
I'm guessing we're doing the similar thing with UMR because they're our
we're working with-
contractor, right?
We all have the same common goal. So we're working towards a resolution to make sure that they can meet all their goals and all their financial obligations, but serve the people we need to serve too. So I can assure you working towards that. Ms. Kelly.
Thank you, Chair Rob. Michelle Kelly for the record. Thank you for that update on the Carson Tahoe because, you know, it feels like this comes up often with Carson Tahoe. Every 3 to 5 years, we're back talking about them sending letters to our employees. And, you know, obviously contracting is always difficult. And I think it seems to be getting more difficult, but I appreciate everyone's attention to it. And, you know, as you say, everyone's working toward a common goal, which is to make sure our state employees in Carson City are served appropriately by the plan. On that note, and I thought it was in your report, Executive Officer Glover, but I wanted to ask about the REMSA ambulance service in Northern Nevada. We've had a fair amount of public comment on that as well, and I've had participant comments about the lack of ambulance service in the north. And I wonder if that's something that also can be elevated, and the fact that we don't have a contract with the only ambulance provider in the north. And I understand that it's covered for participants, but of course their costs aren't capped except for the out-of-network maximum out-of-pocket, which is huge. So I'm wondering, is there anything that can be done about the REMSA situation in the north?
This is Celestina Glover for the record. I did not include the REMSA issue in my report. And we are aware of the public comment. REMSA is not the only ambulance, ground ambulance, for most of the north in the everything outside of Washoe County. Typically the ambulance services are through the fire departments. So those entities, you know, those are the ones that are serving our members, say in Carson City or Barrington or Gardnerville, wherever. REMSA has an agreement with Washoe County. It's a long-standing agreement. So Washoe County covers primarily Reno and Sparks and the surrounding area. Their pricing has been approved by Washoe County. We don't necessarily know exactly what that pricing is. We've had kind of a difficult time trying to figure out what the pricing is. We've asked with UMR if we could potentially get them into the network and agree to some sort of cap on payment. That has not come to fruition. We pay 140% of Medicare. And then, of course, the members, depending on the plan they're on, may have an 80-20 split of that 140%. That is where the issue comes in, is then they balance bill our members. They'll take what we pay them, but then they'll balance bill the members. And we haven't been able to come to an agreement. All we can do is keep trying to get them to work with us and make them an in-network provider. But it's really in their ball court to go along with us. What they do when they balance bill a member is they will tell that member to go ask us to make an exception to the plan rules. And, you know, we can't administer the plan by exception. And so we're hoping we can come up with some sort of an agreement that will work for both parties, but we need that to be a reasonable cost.
Thank you for that explanation, and I totally understand the cost issues. I'm just wondering, the fire department, can you explain to me, so can participants in Reno and Sparks also get ambulance services through the fire department? Do they have options? And if so, you know, I think one of the examples in public comment was a lady who went to urgent care and they said, no, you need to go to the emergency room, and they put her in a REMSA ambulance. So are there options, and how would someone exercise the option in that situation?
This is Celestina Glover for the record. I don't know if there's an option in Washoe County. I've seen some people shake their heads no, but I understand REMSA is the contractor there, but I do understand that there are ambulance services with some of the fire departments, and sometimes those ambulances get to the patient first. So it's kind of whoever gets there first is the one that's going to transport. But I don't know that there's a mechanism where somebody can say, oh, I want REMSA, I want XYZ fire department in Sparks. So, and this is anecdotal. I don't have that information in writing, so.
Jack Robb for the record, being a longtime Washoe County resident and know multiple members of City of Reno Fire Department, they do not have ambulance service. They dispatch to the same medical emergency, but they'll dispatch a truck. They do not dispatch any transport. So you get an ambulance and a fire truck at any medical, but their transport option is one.
Okay, thank you. And I feel like since I've got the mic, I just wanted to, one of the comments I think kind of talked about how REMSA's not for profit. And, you know, that doesn't mean that they don't have high expenses. You know, I mean, not for profit just means that there's no shareholders to pay. It still means they have to pay their employees and their executives a fair salary, or, you know, a salary. So, you know, I'm not sure that not for profit means that the rates that maybe, you know, Washoe has agreed to are low. So I just wanted to put that out there. But I also, I have a follow-up if we're done with kind of REMSA about the wrap document and the oncology services. But I'll wait to see if that's appropriate right now.
I'm fine, go ahead.
Okay, thank you. Executive Officer Glover, I just was wondering if you could share what services are, like, not the level of detail that's in the wrap document, but the wrap document itself kind of breaks out the conditions that we're covering under the regular Center of Excellence. So can you talk about what specific or maybe cancer like, is it by diagnosis or is it by service? And if is it simple for you to kind of just outline some of the major diagnoses or services that are covered under the oncology concierge?
This is Celestina Glover for the record. I can go through the contract and the response to see what, maybe from a higher level, what specific services or diagnoses, at least to get some idea of what's in there. It may not be all encompassing, but yes, I can get that information into the wrap document under the oncology services.
That would be fabulous. And then just as an aside, since staff have done all the work on the wrap document, and then, you know, obviously you've just agreed to do some work on the oncology concierge, is there a way we can put together, or will the concierge services provide a nice glossy brochure that catches our participants' eyes to kind of promote this program, since we've gone to so much trouble to put it in place? What kind of, obviously open enrollment is one thing, but open enrollment, there's so much talked about that people don't take most of it in. But if we could promote these services, I think that would be outstanding. And I just want to also, while I'm talking about promotions, give kudos to the staff for the Hinge Health promotional materials, because I'm being inundated. I definitely know that Hinge Health is in place, and I appreciate that knowledge. So thank you.
This is Celestina Glover for the record. We are right now in the process of going through the implementation with CAREM for the Centers of Excellence, and then we'll wrap oncology into those discussions. Part of that is a campaign of getting the information out to our members, similar to what Hinge Health has done, so that they are aware that that service is available to them. So we'll go on our newsletter, it'll go on our website, we'll do email blast. I believe Karen will do some mailers. So there is an effort, or there will be an effort, to get that information out to our members so that they know that that's available to them.
Okay, any further questions? Seeing none, we will close agenda item number 6 and move on to agenda item number 7. Discussion of possible action, including approving plan year 2025 rates for state of Nevada and non-state employees, retirees, and their dependents for the consumer-driven healthcare plan CDHP, low deductible plan LD, exclusive provider organization plan EPO, and health maintenance organization plan HMO. Ms. Glover, for possible action. It was.
This is Celestina Glover for the record. So as you see, agenda item 7 is to discuss the plan year rates and what our options are. This agenda item is essentially in 3 parts. My report gives you an overview of how the rates are set in the first place. That's probably the same information those that have been around for a while have seen in every report. It's pretty much a copy paste because the process is the same. So when you look at the underwriting, the enrollment, the admin load. So the admin load is essentially our cost to do business. It's salaries, it's operating, it's the admin services fees we pay to our vendors. The tiering, so single participant, a participant plus a spouse, plus children, or plus a family. And then adding life insurance to that mix. One of the things that does go into our admin load that I don't know that everybody's aware of, but our Medicare exchange folks, they go to the exchange and they get their plans through there. So they're not part of this rating except for any of the admin load for the cost for those individuals, as well as their life insurance premium. That dollar amount is spread amongst all our retirees and employees that are on the self-funded and HMO plan. So that all makes up that admin load. I looked at what occurred last year and the year before to get some more recent history. I know what I was involved in years ago, but to get some more recent history. And back in, I believe it was December of 2022, the board at that time had approved utilizing projected reserves to mitigate the rate increases over a 3-year time frame, and that was to cover plan year 23, 24, and 25. We exhausted all of the excess reserves at the end of plan year 23. So for plan year 24, although those amounts were already approved, I couldn't pull them out. Obviously, it was already set in stone. We didn't actually have the reserves to cover that. We are doing okay in the budget. We are projecting a shortfall in some of our claims areas. And so if that materializes when we're probably in about another month or so, then we will have to tap into catastrophic reserves to make that category whole again so that we can pay claims and admin fees per our contracts. So right now, we're kind of watching it and trying to get a better idea of what that number looks like. In plan year 23, we actually had close to a $9 million shortfall in claims for the state employees and retirees. They're grouped together for payment purposes. The shortfall this year is for the non-state employees and retirees. Again, they're grouped together for payment purposes. So that projection is, they're a smaller amount, but it's still something we're gonna, if we can absorb it from within our budget, we will. Otherwise, we'll have to tap into catastrophic. And that is part of the reason we have those reserves, is to cover shortfalls in claims and for any high dollar claims that we may have. We get regular reports to give us an idea of what our high dollar claims look like. And we've had several this year that we use $100,000, but these are $1 million, $3 million, $2 million. So we've got some significant claims. And that's the amount we're paying toward those claims. It's not the bill charges. I just recently received 2 reports in the last week, a $2.5 million claim that we're paying $1.5 million for, a $2.5 million claim that we're paying about $700,000 for. So those are the things we have to be concerned about. And that is part of what is driving our trend and our rate increases, is those types of claims. So I just want to set kind of a stage as to what we're looking at. Siegel, our team here is Richard Ward and Amy Cohen. They're going to talk about trend and what they're projecting for trend, where we're at now, and where they think we're going to be to help us get to where we are with our rates. So with that, I'll take these questions. If no questions, I'll hand it over to Siegel.
All right. Please proceed with 7.1.
All right.
On the agenda.
Okay, so that is page 59 of the board packet, I believe. Thank you, Executive Officer Glover. For the record, I am Richard Ward with Siegel.
And I'm Amy Cohen with Siegel.
And we're pleased to have an audience with you to talk about trends in the self-insured portion of the PEB program. On page 2, which is page 61 of the board packet, the summary version of the trends that we've experienced, that we've witnessed, and that we're projecting. The recent experience in the top table on the right is at and near industry trends. So we have a comparison of PEB trends and what is happening out in the industry. And so for recent experience the last couple of years, medical, pharmacy, and dental is tracked fairly close to national trends. And just for reference here, out of about a $270 million annual claim spend, the majority of it is for medical, that's about $190 million. and about 60 million is for pharmacy, and then about 20 million for dental. So just to keep in mind that mentally put more weight to what is happening with the medical than with the other two trends. In particular, dental is a relatively small portion of the overall spend. Although the trends for pharmacy are significant, and that does have an impact on what we're expecting to see. For the current plan year 24, medical looks to be fairly flat and run. We expect it to continue to run below industry trends, 4% versus 7%. Pharmacy, though, is, as we say, is running hot. It's running really high. This is just claims trend before it's offset by rebates, and it's close to 20% at 19% is what we're expecting for this current plan year, which is about twice what we see in the industry. And then dental is also running at a high rate, but several points of that is due to the change in the annual benefit limit that went into effect for this year. So benefits were enhanced, and that's worth about 4% of the 9 points. So it's still running above what we see in the industry, but a good portion of that is due to the recent benefit change. And then our projections for plan year 25 incorporate what we've seen, what we are seeing, what we expect to see, which includes what we're gathering from industry expectations. So we perform an annual trend survey where we get input from about 70 insurance carriers, administrators, PBMs, and all the Blue Crosses, all the Kaisers, United Healthcare, UMR, and Express Scripts. They participate, and they tell us what, as an organization, they are expecting for trend. And we amalgamate that into what we're representing here for the industry. So it's not Siegel's expectation necessarily of what's going to happen in the industry. We're synthesizing the industry's expectations into a report. And that also helps, one, it provides a benchmark for discussions like this, but it also provides us that broader perspective of what the industry and the market is anticipating. And so we incorporate that into our assumptions for plan year 25, which has a slightly lower medical trend of 3%, a higher pharmacy trend of 10%, and then we expect dental to come back down to to be more in line with prior experience at 2%. I'll move on to the next couple of slides where we have a little bit of detail for medical, pharmacy, and dental respectively. In this graph to the left, so this shows the per capita costs on a rolling 12-month incurred basis. And it's I think a good graphic way to see how costs have evolved over the last several years. And you may note that in the far left here for 2020, costs were substantially lower than what we see in the most recent 2 or 3 year period. But that was when PEB and the industry in general was experiencing the COVID effect, where people were not accessing care in the way that they had prior and that they have subsequently. So trends for 2021 in particular, you can see for PEB in the table at the bottom, is about 15%, and that's due to a bounce back relative to the suppressed costs that we saw in 2020 when COVID was new. And then since then, PEB's trends in the table in the far right are in low single digits. And this is a comparison of the governor's budget trend, and then pricing trend is what we assumed, or the actuary at the time prior to our working with PEB assumed for rating purposes and budget projection purposes. And you can see that generally speaking, the budget trend is lower than what was assumed for projections, and then generally speaking, is lower than what actually happened. And then for pharmacy, it's the same format of the graph where we're showing a rolling average for per capita cost, per member per month costs. You can see that it's increased fairly steadily from the top line there, claims cost, $164 in the far left in June of 2020, growing steadily to $263 or $240 currently through December. And then the dotted lines for the next 6 months indicates what we're projecting for the second half of the current plan year. And drug utilization and drug claims were relatively unaffected by COVID because people could still get their meds, have mail order delivery. And so it wasn't the same effect on accessing care and utilization and costs. So there wasn't really a dip for pharmacy for COVID like we see with medical and dental. And those trends are continue to run at a high level. And in the PEB plan, 3 primary drivers for the pharmacy trend, although not the entire story, but three important factors are GLP-1s, which are weight loss medications that there's been this is an industry-wide, market-wide phenomenon where costs have come from a very low point, low utilization to fairly high cost, couple of $1 million in the plan just in the last year or two. And this is not a PEB-specific phenomenon. We see this in really all of our clients. And then also anti-inflammatories and diabetic supplies and insulin continue to be drivers of trend. The lower line, the orangish line, is net of rebates. So true pharmacy costs are the claims costs, and then once we consider the rebates that Express Scripts collects and passes back to PEB, that's how we get to the true pharmacy costs or the net pharmacy costs. And that is tracking at a lower level and at a lower trend rate. So for 2024, while we're expecting claims costs to increase 19% for the plan year, that's offset by enhanced rebates, which lowers the trend to 10.8% by our projection. So still a high rate of increase, but not as high as the 19%. And you can see in past years, similar effect, especially for 2023, which reduced the gross costs by about the same amount, by about 9 points, from 14% to about 5%. And then for dental, consistent with what we saw elsewhere in the market in the industry, dental costs during the COVID period, again, far left of the graph in 2020, saw the most effect for dental. People deferred care, didn't have their annual checkup early in 2020. And then once we get into 2021, especially later in the year, calendar year of 2021, you can see a return to care. And then in PEB, relatively level costs over the next two-year period or so. And then now we're seeing in 24, plan year 2024, an increase in costs. And while the trend increase is close to 10%, it's an increase from $51 to $55 is what we're expecting. So it's a relative per capita cost. So while it's a large percentage from a dollar basis, it's still low single figures. And again, about half of that is due to the change in the annual benefit limit that went into effect for this year. Now, just a few more words about our trend survey. So again, I'm on page 65 of the board packet and page 6 of our materials. So every year we survey the industry, carriers, administrators, PBMs, and to get their expectations for trend. And then also, what their actual trends were. And we've done this for over 20 years. So we have a we have a good history of tracking what expectations were relative to what actually happened. And generally speaking, the industry is conservative with their trends. And I think that's not surprising. When we look at actual trends with the benefit of hindsight compared against what had been projected, we generally see that the actual is a little bit lower than the projected, with some exceptions. I mean, there was a period where pharmacy costs went up at a higher rate than what the industry expected, but generally the industry is conservative by a little bit. So the next couple of slides compare industry expectations, the actual that the industry reports that they expected, that they experienced, and then PEB trend. And we'll go through this by medical, drug, and dental. The first slide of these graphs on page 7 of our materials, page 66 of the board packet, shows medical in the dark blue, purplish graph line. Pharmacy is in green, and dental is in orange. Just to see how trends have fluctuated over the last decade or so, or not quite decade. You see pharmacy costs were higher about 8 years ago, 9.6%, dropped down to a lower level, about 5%, and then in recent times have come back up to 10. And again, this is industry-wide. And this is actual experience, and then the last figures here are projected, or what the industry is reporting as expectations. And then medical has also moved around a little bit, especially beginning in 2020. And dental has been fairly consistent except for the COVID era in 2020 and immediately after that. So now let's move to the next one, which is page 8 of our materials. And the teal line that moves around more, looks more like a sine graph, I suppose, is PEB trend. So PEB trend in plan year 2020 was negative, and that was when that was during COVID, when people were not seeking care, especially routine care, like they had been in previous years, and then jumped up to 14.9, like we reported a couple of slides ago for the bounce back, and then dropped back down to lower levels. The solid line is actual industry experience, and then the dotted line is what the industry projected. And so I was saying in 2020 and 2021, expectations were higher than actual by a little bit, and then now we're seeing that industry is continuing with a fairly consistent projection of about 7.5% for the next couple of years. And we expect PEB's trends to continue at a few points lower than that. Pharmacy is a different story. Same colors, and same PEB is the teal line for claims costs. And you can see we're projecting that claims costs will continue to increase at a high rate. 14.3 was the actual trend in plan year 23, and then we're expecting that to be almost 20% in 24, but reduced by rebates. And that's the lower purple. Thank you. I am slightly colorblind when it comes to shades. So don't ask me about different shades of green or purple. I'm a little handicapped there. So the 5.1 is just to orient us here, is the net of rebates, and then we're expecting that to be 10.8%. And then you can see that the industry has been, for 2021 and 2022, pretty good at projecting what costs would be. That's why those lines are so close together. And then dental, you can see PEB trend oscillating quite a bit above and below industry expectations, which continue to be in the 2 to 3% range. Okay, just a quick word on what the main components of trend are. That you have unit cost trends, so just the cost of prescriptions, the same pill, the same medication, or the same treatments. So an office visit may increase from, say, $100 to $110, and that would result in a 10% trend for office visits if utilization remains consistent. Utilization also changes from year to year, so the two together can work to offset one another, or they can compound in one direction, upward or downward, depending on how they're moving from year to year. And then another component is just what we call utilization or case mix. So you may have an example of that is generic and brand medication. So someone may be on the same therapy, the same medication regimen for a condition, but if they switch from a brand medication to a generic medication, the utilization is the same, but they've switched to a different cost of therapy. And so that change in mix can also affect trend in either direction. Some of the challenges that we're seeing, we continue to see challenges with medical providers in the cost of labor and just the cost of supplies. So as we're seeing with a number of industries, the cost of doing business continues to increase. And so we're seeing provider groups across the country wanting to negotiate different terms than they've agreed to historically in some instances. And then I'll just move to Executive Officer Glover talked about the methodology a little bit, so I won't belabor that, hopefully not too much. But on page 13, page 72 of the board materials, the main components of our analysis, that we take claims and enrollment, we project them forward by these trends, we make adjustments for changes in benefits, or maybe there's new programs that are being implemented. So for example, the Center of Excellence network, as that goes into effect for the next plan year, we're making an adjustment for the anticipated impact of that coming online. Same for the oncology concierge program. And then we add administrative fees, so the medical, pharmacy, dental, ASO fees, and any other applicable fees that Ms. Glover mentioned. And then we develop those rates by coverage tier and by plan rate using the established methodology that the board has approved and directed to be utilized. And the next couple of pages have some more detail on that. So the next one has a summary of our trend assumptions, and then a summary of the changes that we're accounting for, such as the increase in the deductible for the high deductible health plan, and the copay changes for the EPO and copay plan, and the other programs that I just referenced. And I think that'll conclude the prepared comments. So I'll take questions if there are any.
I don't know if it's a question or some statements, because I'm listening to what you have stated. And just for everybody to know, I did have occasion to meet with the Siegel Group and Executive Officer Glover in between meetings to go over some of this. And I've read all the public comment and looked at where we're at. And some of the things I want to put on the table today is there's some assumptions in some of the public comment that we have a bigger reserve than we do. Listen to Ms. Glover's comments about some of our major claims that we are recognizing at this point. So what we show on paper as a reserve, we really don't have, because these major claims have taken a bigger hit than anticipated. The cost for everybody continues to go up. The weight loss drugs, Nobody could have forecasted that. It's stuff that's happening nationwide. Where we missed, industry misses, everybody misses. We're all on the same page, like I said, on other items. We're to provide quality care at the most affordable price to our plan participants. That's staff's goal, that's this board's goal, that's all of our contractors' goals to do that. It's trends, that's all we can say. You forecast, and I always say hope's not a strategy, but that's what we rely on, is hope. And that's really not a strategy, but we do our best. We do the best as a board. I know staff does their best because they're subject to the same cost increase as we are. And nobody's immune to this. But I think there's some compounding issues. Having 3 plans and the plan confusion and the plan migration between plans because of the confusion, I think that can be a confounding issue. I think we need to look at the possibility of going back to 2 plans to keep some of this swing out with the plan migration. Because what I understand is somebody thinks something's better, so you get a migration here, but then it affects those costs and that forecasting going forward. So it becomes even more difficult when you put 3 plans in the mix. It compounds the issue, so our forecasting ability is limited with 3 plans. It could be much more streamlined with 2. I'm summarizing. I'm gonna look at the Siegel Group and Ms. Glover to help me through some of this, but I just want to put some of this on the table before we start discussion. So the possibility of going from 3 back to 2. And then another thing I want to talk about is we're doing our best to recruit employees in the state of Nevada. And when you recruit employees, a lot of times they're in entry-level positions. With these cost increases, it is hitting our entry-level employees much harder than it is our more senior staff. And I want to put on the table, maybe we look at going forward, some type of plan design that if you're under 30, it's X percentage instead of a flat dollar amount for everybody. If we could come up with a flat percentage of gross pay, we can equalize some of this stuff out. One of my concerns is in our lower salary grade individuals, we fought both sides, everybody, to get state workers more money. But on our lower salary people, pretty much 100% of their pay raise that we have afforded them is eaten up by these increases. They're not seeing any appreciable income adjustment. So somebody in a lot of our positions that sit at this table, we're more tenured employees and we have a higher salary. We still recognize the pay raise, even though we have an increase in premium, but it's not 100% eaten up. So I'm looking to maybe explore different options going forward as to how we can equitably right size this so that everybody feels the same percentage of pain. My tax premium, everything, if you look down below on your paycheck stub, everything is on percentage, but healthcare is a flat rate. And maybe it's time for the board to ask staff and Siegel and others to explore different options on how we don't hit those lower tier employees as hard as they are. So those are just my thoughts. I would ask Ms. Glover to correct my thoughts if I missed anything throughout my time. And I would ask the same of the Siegel Group to maybe clarify some of the things I might not have stated exactly correct. And then we will start some further discussion around the table, and then we'll come out with a plan to go forward.
So this is Celestina Glover for the record. Going off with what Chair Rob has just said, internally, we've already started some discussions, very preliminary. I talked a little bit to Richard in a meeting. What are our options? What can we do? And this was predicated on the comments that were made regarding how we apply the employer contributions. What is the best way to do that? Is it a percent so that the lower paid employees are not as affected by rate increases, while still making sure that, you know, we are funded the way we need to be in order to make this plan work. So those are things we will be bringing back to the board when we have some more concrete ideas of what that might look like, how that might affect how we rate the plan in the future. What changes are we gonna have to bring potentially during the budget building cycle? Will it require us to make any regulation changes, statute changes, any of those things? So we are looking at that because we do understand that rate increases are not something that everybody can absorb without any problems. For some people, maybe, you know, a $20 increase may not seem like much, and for others, it's a lot. So we are aware of that. We try to do everything we can to mitigate those increases. But at the same time, we have to deal with reality. And part of my review in doing this report this time is I went back in history to see where our rates have been and what have we done over time. And we've done a combination of things. Sometimes, you know, a lot of times when it's an economic downturn, budget cuts, you know, flat budgets, whatever we're directed to do, it's resulted in benefit reductions. We've reduced life insurance, we've increased out-of-pocket costs, we have reduced benefits within the plan. Like, we've done everything in that realm. Not ideal because nobody ever seems to know what's covered and what's not covered, and to what degree is it covered. So I'd like to try to get away from that habit and determine what our plan design needs to look like and leave that alone other than technical adjustments because, you know, there's been some federal law that's changed, some state law that's changed that requires us to do something different in the plan. But what does that plan design look like? Are we there right now? Probably not. Can we get there? I think we can. I think it's just going to take some analysis and some work, and we'll work with our partners to determine what that looks like. Then it's the cost of the plan. So we have the plans rated according to trend, experience, everything that Mr. Ward has explained in his report. That has been considered in every year that we've done any type of rating to set our premium and our employer cost. When I look back, I went back to 2013, and our plan rates premiums to the employee have been relatively flat since 2013. So we've been in that $30, $35 range to $45, $46 range for a single person on the CDHP for quite a long time. And part of that is because we did use excess reserves when we needed to keep rates flat. As I said earlier, the reserves have been exhausted. It was mentioned here that we had $7 million in reserves, in excess reserves right now. That is, as of December 31st, that is our cash on hand. It is not reserves as of yet. It is captured in the reserve area, but our projection is a negative $17 million for the end of the year. We're gonna run those projections again next week to see what the third quarter looks like. But that means moving forward, we have a hole in the budget in excess reserves, which is gonna affect our available cash going forward. And that's a lot of technical stuff that I'm not gonna try to explain at this point in time. Just want you to understand that excess reserves right now, based on our budget projections, do not exist. 7 million, -17, that's a -10. So, keep that in mind. There is proposal for mitigating the increase, so there'd still be rate increases, but not to the degree that we're seeing in the rate tables. That is going to go against catastrophic reserves, which we can use for rate stabilization. But part of the purpose of catastrophic is to offset the cost of those high dollar claims, whether it's in medical, pharmacy, wherever it might be, that, as was stated earlier, is not anticipated, that we can't really project. So that is kind of our, that's kind of our safety net, for lack of a better term. It's our pot of money that we can go to if for some reason what we have in the budget is insufficient to cover those type claims and any other costs that might come up. So I just want people to fully understand that the excess reserves as of today do not exist in our plan. It is going to come out of catastrophic reserves. If we should have a good year and we don't see that we're going to exceed our budget allowance, then we'll leave the catastrophic alone and we'll live within our means. But if we should need it for whatever reason, then that will be our avenue. And so with that, before we get into the tables, I see people wanting to ask questions, probably to Richard, so I'll stop here and.
Richard, do you have anything further that, from what I said and what you heard Ms. Glover say, is there anything that I missed upon that needs to be clarified? Did I miss anything during my statement?
Richard Ward, for the record. No, I don't, you did, nothing was overlooked. One additional comment is that regarding the plan options, I think somebody mentioned that, you may have mentioned that there's migration between plan options. And when there's movement between plans, that creates usually pressure on plan costs. So it results in increases in plan costs as people are migrating from between plans. And having two plans relative to three can generally lead to a more stable overall risk pool. So the risk, if membership and enrollment remains constant within the plan options and there's not movement between on an annual basis, then things are more stable and a little more predictable.
Thank you for talking about the migration between plans. I know, even sitting in the position I sit in currently, I have confusion with the three plans. I'm not going to say I don't. And I think 99% of our participants have confusion between plans, and that causes some of that migration because we have the three options. And too many options sometimes causes more confusion than I want to have options, but I do believe that the three options confuses me even more than if there was just two. And so I just want to state that, and we will start with Vice Chair Kelly and questions or comments.
I have so many of both, so excuse me. Firstly, Chair Rob, I welcome your wanting to explore premium options or employee premium options and plan design options. I think it's time. I would say, though, that our membership petitioned very hard to get the second PPO, or a PPO that actually covered medical, in the same way that the HMO covered medical. We had the high deductible and an HMO. So, our membership worked really hard to get that mid-tier PPO. Not saying that I'm closed-minded to two plans, but I do think that we need to give these structural changes to the way benefits are offered to the state employees the time and discussion that is necessary for making big changes that only will happen every 10 years or so. So I welcome the opportunity. I hope we would do it in a strategic planning session where we can kind of look at both items individually and get constituent feedback and really take a considered deep dive into how things are currently working. That's my comment on that. I think it's a great idea. So thank you for your willingness to explore those items. I have a lot of questions about trends. So before I go on, if anyone else wanted to respond to Chair, I don't know if we want to structure this in some way or just a free for all. So I'm looking to you, Chair Rob, to how you'd like to handle this.
Go ahead, Ms. Ayala.
This is Betsy Ayala for the record. Just a quick question to what you said, Ms. Glover, is that there have been a few kind of unexpected high cost claims. Is that because of an unexpected medical condition, or is there something new in medical care that is occurring that we might expect that to increase more? I mean, maybe that would have come in the trend, but I could see that as there's new medical processes and procedures, they may be expensive. So I think my question is, okay, we've had this and we had some reserve, excess reserve, now it's gone down and we're going to, is that something that we would expect could continue to happen because of something that's happening in healthcare? Or would that have shown up in your trends?
So this is Celestina Glover for the record. So the high dollar claim, the two examples I provided, they were a result, those specific claims were a result of some medical conditions that.
Okay, and
were
not
expected.
changes in medical science
Not
type thing.
necessarily
Okay.
treatment.
So it's not really expected that that would continue to happen, is it? I mean, you can't see into the future, but.
Right. This is Celestina Glover. I mean, if somebody, comes on, who's new on the plan, comes onto the plan and they have a genetic condition that results in expensive treatment, expensive medications, that obviously that's unexpected. It can happen. It does. We've had that happen. Or it could be something as simple as an accident or something of that nature that results in long-term in facility care. There's a lot of things that could happen. That's not to say that there isn't the possibility of a change in treatment methods. New medications come out all the time, and when they come out, they're typically much higher priced until, a bunch of years from now when they finally become a generic, if they ever do. So I think it's probably a combination, but the examples I provided were the result of medical conditions.
May I comment?
Yes, please.
Richard Ward for the record. In reviewing the top 20 high-cost claimants for each of the last 2 years, more than half of those 20 are what we would consider episodic.
Okay.
So it's due to a specific instance or circumstances. And once that is addressed, then we wouldn't expect that particular individual to continue to be at that level. There likely will be someone else, so that'll cycle through. So it's due primarily just to normal fluctuations for episodic high-cost claims.
Thank you.
Any other comments, questions within the room before we go back to Board Member Kelly?
I have a question. Leslie Billiston for the record. I guess I have two questions. The pharmacy trend seems to be extremely high, and I'm not sure if this is a Express Scripts question or a Siegel question, but it doesn't seem like the $2 million in diet medication would account for all of that. I guess that's one question. I guess another comment, the diabetic drugs and supplies are astronomical. You've got insulin needles, pumps, all kinds of things that are just extremely expensive. Anyway, my second question is about the governor's finance office. They seem to have been estimating trends a lot lower than our actuaries over the last couple of years or few years. And so my question is there anything the governor's finance office can do to increase the subsidy the state is paying for medical or for those rates?
So this is Celestina Glover for the record. Historically, that has been the case. We've come in with a trend of whatever, 5-6%, and the budget office has reduced that. Part of the reason for that reduction too was because even though we were projecting, say, a 6% trend in medical, we kept experiencing positive, which is a good thing. We were experiencing positive years. So the claims we thought would come in didn't occur. We took as many steps as we could internally to introduce programs that would help save the program money as well as the members. So I think that combination is how we ended up in that area. So we're saying we need, $100, and they're saying, no, we think you really only need 90. And it's just because they are looking at historically what has happened, and we're trying to project forward. We're saying this item's gonna cost $10, and based on the information we have and what we expect, and they're saying, no, we think it's $9. So they're likely to do that in the future if they feel like what we're bringing to them is not reasonable. But we will work with them to give them an idea of what our history has looked like and, where we think we're gonna be, so that we can hopefully come to a more level agreement. If we're saying 6%, that they're somewhere in that ballpark as well. I think we were relatively close. Pharmacy was probably the outlier, but I think we were probably relatively close on the budgeted side versus what actually has happened. But again, some of that is probably driven by some of these high dollar claims that we couldn't project. So.
And the higher cost of supplies, like Mr. Siegel just said
Exactly.
a few minutes ago about just the cost to do business. And it seems like we're missing the mark on our projections on the cost of doing business. So.
That's correct.
Betsy Strasberg, I also noticed that the budget office has the same percentage for year one and year two. Is that something that could be addressed during the budget process, given that fluctuations are happening more often than before?
This is Celestina Glover for the record. We can address all those issues, and we will. We will present to them with the help of Siegel what we believe our budget should look like, and that will include projected trend going forward. And that's going to be based on what we're seeing over the last few years, what has happened even past that, and try to sit down and have some discussions. I've already asked the director of GFO if we could have a sit down, just her and I, to discuss, what she thinks they may do and what I think we probably are likely to do as far as our request. Go ahead.
Hi, April Karn for the record. Just a quick thank you to you, Chair Rob and Director Glover, for kind of walking us through some of the options that you're already exploring. I am interested to see where maybe we could head with regards to looking at the current plans that we have and options there. Also, the use of catastrophic funds and how we might be able to incorporate some of that. I think we are hearing from the public that our services are not competing with the costs, and that is very concerning to me because we continue to raise prices and they're not getting the services that they need. Also, and interested to hear, have you explored what other states are doing from a public perspective? What do their plans look like? And how does Nevada kind of fit into that? Maybe there might be some other plan options that we're not aware of that could be already in existence where other states have already kind of run into these issues. And I'm just wondering if we've considered that or looked at that.
I think that's where the signal group comes in, and that's
Yes.
part of what they're contracted to do.
Richard Ward for the record. Siegel works with about 25 state health plans nationally and 10 here in the West. And within the Mountain West, the premiums for the PEB plans are within, I would say, are comparable. There's one state that is an outlier, but if we look at Idaho and Montana and Colorado and Utah and Arizona and Wyoming, the premium levels are comparable. From a plan design perspective, I would say there are some other options to look at, but primarily PPOs and where the market supports it, HMOs are the primary design structures that are used. And there's a mix of use for CDH plans. Most states do have a CDH option. PEB is unusual in the level of enrollment in your CDH plan. In a lot of states, it's offered as an option, but they generally don't have the same enrollment that the PEB CDHP plan has. Usually it's below 10%.
And April Karn for the record, just one more quick question. In those other states, are they looking at the economic situation for like entry-level positions? Do they take that into consideration when creating their plans? Have we seen
Yeah.
where that's and
Sorry.
go ahead.
Richard Ward for the record. Yes, and one of the things that we often do is work with our clients to consider sometimes we call it the mission statement, but what's the reason for a particular plan option being offered? What need is it looking to fill? And that way, as Chair Rob was mentioning, you can address you can have different options that serve a specific purpose. And so you can have a plan option that might appeal to one segment of the membership that might value a lower cost option, and that might come with a leaner benefit design. And then you might have another plan option that has better benefits, but might be more expensive and would appeal to that segment of the membership, and so on. So that's something if you're thinking about it from a strategic review perspective, we found that to be helpful to serve as provide some guidance in thinking about how to construct different plan options.
Thank you. April Karn for the record, just one more thing. I don't know, I don't recall the last time that we actually did a survey out to the community, out to our members, but I think that it might be something to consider that we throw out some of the options that we're exploring, or that we reach out to hear and gather a little bit more information about what it is that they're wanting. I was honestly a little bit surprised that we didn't have more public comment around this issue. And I don't know if it's because people just aren't comfortable or what, but I think it would be really a good idea to consider, just really giving our members another opportunity to weigh in and share. Thank you.
Any other comments in the room before we go back to Vice Chair Kelly? Please go ahead, Vice Chair Kelly.
Thanks, Chair Rob. So I have some specific questions around the trend that I'm hoping Mr. Ward might be able to help with. Firstly, and maybe I'll just give you my question so that we don't have to go back and forth on the video, because I know that can be kind of distracting, and I apologize for being on video today. Okay, so the first question I've asked before, and I think, when I'm looking at the breakdown of medical, pharmacy, and dental, 6.1, 4.0, 19.2, 9.4. I would like to know, of 100% of those three trends, how much money we're talking about. And then for PEB, and I'm talking specifically for PEB, so of medical, dental, pharmacy, how much is our spend, say annually? And then what portion of, if you think of that spend as a pie, what portion is medical, what portion is pharmacy, and what portion is dental? Because obviously, I know from Executive Officer Glover that dental is a tiny, tiny portion of the big pie, but I'm just curious about the split, especially the split between pharmacy and medical these days. So that's my first question. And then my next question is, obviously the focus here is RX, right? I mean, I think medical we can kind of all understand, but I'm still trying to get my head around how pharmacy works because, obviously none of us are experts. So when we're thinking of pharmacy, Mr. Ward, you said that the top 3 trend drivers with pharmacy were the GLP-1 weight loss medicines, the anti-inflammatories, and then 3, I thought you just said diabetic supplies as opposed to diabetic medicine, but you can correct that if I'm wrong. I wanted to inquire about the weight loss GLP-1s, which is number 1 on your list of drivers. I assume these are in order. So this weight loss medicine is driving the trend the most. But what I'm confused about is that PEB doesn't really cover weight loss medicine unless you're on the specific PEB program. And then we only cover generic drugs. So we're not covering the stuff that's getting a lot of media attention at the moment, like the Wegovy's, and I don't even know all the names. I know there's quite a few of them.
Mhm.
So how is that driving how is that driving our costs if we don't even cover them? That's the question. And then let's see. Specialty. So actually, I have a question about the rebates because obviously our costs are our trend is 19% before rebates, but comes down significantly after rebates are applied. And I'm going to show my ignorance here and ask you to do a Dummies 101 on what exactly the rebates are and how they work for the plan. So I understand rebates when I go to the Safeway or whatever the stores are called these days, and I hand over a coupon, I get a lower price. But I'm not really sure how they relate to health insurance. So if you could help me there by answering that question so I can understand why they're so prevalent and they bring the cost down so much, which I'm grateful for, don't get me wrong. So that's that question. And then talking about specialty meds, I always thought kind of specialty meds were the compound stuff, and obviously their use is exploding. And I see that they're still kind of unique kind of drugs. So we're not talking about brand name drugs. And I'm phrasing this is more a phrase, but please correct me when I'm wrong, because I probably am. So these specialty meds are kind of compounded, or they're very unique infusion kind of drugs. So I'm just wondering, and there's more and more of them being introduced. So for our participants, I guess I'm wondering, and for the plan, I'm wondering a few things about the specialty things. So firstly, are there a top 5 or 10 conditions that specialty meds are being developed for and rolled out for? Where's our top spend for those medical conditions, or what are the medical conditions that we're spending specialty on? When people get specialty meds, is there like the step therapy like there is for other regular medicines, or if they need this specialty med, they just get it? That's my second question around specialty. And then my third question is, and this is, I apologize even as I say this, but are there plans limiting access to specialty med if they're really driving costs to such an extreme? Are plans doing unique things in this area to kind of try and cap costs? And that seems like a lot of questions, but I appreciate your patience and everyone's patience. And hopefully you can answer those. Thank you.
All right, this is Richard Ward for the record. I may need a reminder here or there on a particular aspect of one of the questions. I took some notes and I'll endeavor to respond here completely. But if I overlook something, just remind me, please. Going to the first question, which is the split of costs by medical, pharmacy, and dental. I'm gonna use round figures here. Of a $270 million annual spend, about 190 million is for medical, about 60 million is for pharmacy, and about 20 million for dental. So with a 4% trend on 190 million, I'm gonna make the math easy here, at least for myself, that it's just shy of an $8 million increase. For pharmacy, about a 20% trend on 60 million is about 12 million. And then on dental, it's 9.4, let's say that's 10. So 20 million translates to about a $2 million increase. For the trend drivers, the pharmacy trend drivers, you are correct. The plan only covers generic for GLP-1s and weight loss medications. PEB only covers generics, which is most plans provide broader coverage. And so covering generics does reduce the exposure to PEB for these medications, but the increase in those medications that are covered has been significant over the last couple of years. And even though they're generics, they're still higher cost medications than most generics. They're not in the $3, $4, $5 range, like you might think a lot of generics are. Then for rebates, there are, for brand name drugs and for specialty drugs, the drug manufacturers will provide a rebate for specific medications to offset the cost. So you can think about it along these lines. If a drug costs, let's say, a month's supply costs $2,000, there might be a $500 rebate that is paid, that is provided by the manufacturer to offset the cost of that drug. And Express Scripts and every other PBM in the industry negotiates those terms with each of the drug manufacturers. And that is incorporated into the development of their formularies and how those are constructed. PEB has an agreement in the contract with Express Scripts, which we renegotiate every year to ensure that it remains competitive, has a minimum rebate guarantee per brand drug. And for the current contract those guarantees are for specialty medication, they are about $2,600 per script. So for every specialty medication that's filled, Express Scripts is guaranteeing that PEB is going to receive $2,600 in a rebate to offset the cost. Express Scripts is passing back 100% of every rebate that's collected. So that will vary from medication to medication. And ideally, the actual amount in aggregate on average will be more than that $2,600, but that's what is guaranteed to the plan. For non-specialty, they're at lower levels. For a 30-day prescription at retail, it's about $300, and then it's about $900 for 90-day, either 90-day at retail or mail order. And again, that's for non-specialty. Specialty medications in this context are not compounded medications. They're more biological in nature. And you think of an example is Humira, which is often the most utilized drug in a plan's experience when we look at the top X drugs. And that is a high cost medication. So that falls under specialty. And until recently, there haven't been alternatives for these specialty medications. So there are things now that are emerging, biologic equivalents. You can think about it like a generic, it's parallel to there being a generic alternative to a brand medication. Until recently, for these specialty medications, there hasn't been a clinically equivalently effective alternative. So when someone needs a specialty medication, whether it's Humira or maybe it's an oncology medication, they need that particular drug for their particular case, and they don't have another option. So there's not a steerage opportunity like there might be between many brands and generics. And we don't see our clients limit coverage for these higher cost medications. Because generally, especially with public plans and employers, public sector plans and employers, they have a focus on access to care and providing quality care. And they try to do so as affordably as possible. And so not covering a particular medication that someone may need for a rare condition or a complicated condition or a condition that requires a complicated treatment is not something that our clients generally do. And then I think hopefully I'm working through these. The last is about the higher cost conditions or the top conditions that constitute, that drive pharmacy spend. So you would see, or for specialty, so you'd see things like anti-inflammatories, which would be Humira. You have oncology medications, and what are?
Also the utilization, patients.
And then is this in the board packet?
Yes, page 32.
Okay, on page 32 of the board packet, I think it's in the consent agenda. There's some utilization reports that show the top medications and the top classifications or drug classes or condition classes. And so we see a lot of oncology medications in the top 10 or 20, specialty in the list of specialty medications or classes that are used, and then anti-inflammatories. And then you'll also see things if in rare instances, if someone, for example, is
Transfer it.
yeah, come on. If someone has what's a hemophiliac, thank you. If someone is a hemophiliac and has the treatments for hemophilia are very expensive, and you may or may not have any or more than one or two members that need that treatment, but when you do, you'll often see just that one or two prescription rise into the top 20 from a cost perspective because it's such a high cost treatment. I'm not sure if I answered everything there, but I'll, at the risk of continuing to belabor the point, I'll pause.
If there's any follow-up questions within the room before we go back to Vice Chair Kelly, any follow-up questions?
I guess one more question. This is Leslie Biddlestone for the record. Do we, as a board, need to make a decision today on, or do we need to vote today on what is being presented? Or is this where we're gonna send some more stuff back to Siegel to?
Or Jack Crow, for the record, my understanding is we have to make decisions today, but we need to look at other options, look at keeping three options, going back to two, different rates for different salary bands. All the things that I throw on the table are not today decisions. Decision on where we need to go is a today decision. Decision on some of the stuff that I suggested we start looking at as a board, or future decisions to be made after Executive Officer Glover and Siegel give us more direction and more information to help with that decision making. Yes.
Betsy Aiello for the record. Based on what you just finished saying, Mr. Ward, that medical is the high cost of the items, and looking at your PEB and industry, every all the years, PEB has actually come below or is projected to be below the industry, which then would either indicate we're managing somewhat well or lack of access or whatever it is. But for the rate costs and the projections, since the majority of it rides on medical, that's fairly good, I guess, at least, even though we're ending up with a huge rate increase because of prior ways we've been spending money or lack of the governor's budget or whatever it's been, correct? Is that,
I would, Richard Ward for the record.
you don't want to comment then?
Well, I would agree that the recent trends on medical is an indication of a combination of effective management. So you've been looking to implement and introduce measures to make the plan more efficient. So I would say the Center of Excellence Network is one example of that.
Yeah. And
There's also some chance and luck involved in that too, because claims costs will vary on their own. And so you've had a couple of year period of good experience. That happens. Overall, even though medical is the majority of the costs, the high increase on pharmacy is having an impact on the overall trend. And so we have 4%, 20%, and 9% trends that averages out among the 3 to the 6 to 7% range, because the pharmacy is so high, even though it's not the majority of the cost, it does bring that average up. And so the trends from last year to next year are higher than the increase in the Aegis and the Reggie.
Which, as a follow-up question, then doesn't make as much sense, because you'd think, well, we have a healthy group if our medical's down, but all those changes in meds and things are happening throughout the country, not just
Right.
in Nevada. So it
Right.
kind of is a disconnect if our medical is so high when, I mean, the medical has been maintained, but the pharmacy's going really high for some reason.
Richard Ward for the record, there is at times an inverse correlation. So if people with chronic conditions.
If they're more compliant with.
Correct.
Yeah.
So that will increase pharmacy costs,
That makes sense.
but level out medical costs as you're.
Thank you.
As
Yeah,
you're
that's a good.
managing the complications that may come with chronic conditions.
Okay, and go ahead.
Agree. Janelle Woodward for the record. I think to your point, sometimes we don't know why the medical was a little lower. What I hear a lot from our lower staff, lower level staff, is that they can't afford to go. You can't afford the copay to go and get your MRI done or your whatever test that has a high copay. You know, taking that, you can't afford the more expensive drug because Express Scripts doesn't necessarily pass that on to the employee, because you're required to get it from them. But if you go to the local pharmacy, they're going to pass that on to you. So I think that those things all play into that, where our fellow employees just can't afford that. And it's unfortunate, but it's a reality. And I think that's just something to keep in mind when we're looking at developing what can we do going forward. Can we make better plans by just going to 2? Fix the cost by, making it based on your income, just different ideas that you flesh out and see. But while we're trying to be fiscally responsible with everything, we also have to keep in mind the people that this program is for. And if you can't afford it, it's like, why pay for insurance that you can't afford to use at all? And that is a lot of what I hear. I have that situation sometimes as a cancer survivor, that you can't really afford, can I afford to go get that MRI done, or should I do this instead? Can I afford that medication? or not? Or can you even get it because everybody in the world is on it and there's a shortage? And so I think that, again, it's just important to keep in mind who this program is for.
Before we have any further discussion, I'm gonna ask Executive Officer Glover, there's multiple options on the table, and then we can have further discussion. And none of the options are gonna be good. They're not gonna feel good. They're gonna be difficult, but we sit on the board to make difficult decisions. That's our job. But there's probably a good decision, a semi-good decision, and a poor decision to be made right now. And I want your input as to the best path forward out of all the options. Knowing what our reserves are, knowing what our catastrophic claims are, knowing you have more information than anybody, so I would like some guidance, and then we can have further discussion upon what your guidance is.
Celestina Glover for the record. So included in my report were several tables. One was the rate table. This is a preliminary table. It's not the final, so you'll see the employees portion may be a little bit off from what the other tables show, but I just wanted you to be aware of that. So that is the table that just says plan your rates. It looks like this for those of you in the room. Page number on it. And that's just an overall rate. So it's going to show you the rate, the subsidy, and then the participant premium for the different plan and tiers. Then I put together a premium comparison table. And so this is the employees portion of the premium comparing 2024 to what we're looking at in plan year 2025, and then what the difference is. So if you look at the CDHP for a participant only, it was 46.96, their portion. We're looking at 63.56. The difference is $16.60. And then it compares all the plans and tiers accordingly. So that is just more of a picture of what those premiums look like if we just take the rates as they are calculated currently without making any adjustments. That's what it would look like. Then I did a table, mine's two-sided. So on the one side, what I did is I took the premium, so the employees portion, that table shows 2024 premium, 2025's premium, the difference between the two, so you could see what that increase was. And then I took the dollar amount that was applied in plan year 24, utilizing excess reserves to bring those rates, to keep the rates flat. So the $7.22, that was applied to the CDHP single participant, and that's what all of these amounts reflect. I took that dollar amount that was applied to the employees only, and then applied it to the retiree groups, both the state and non-state groups. So we're using the same dollar amount across the board. The other table, which is probably the one I would recommend, is the 50% table. So what that does is take the difference between 2024 and 2025 and says, okay, the increase is X, take 50% of that and pay for it utilizing catastrophic reserves. The other 50%, the employees are going to see that price increase. So instead of the $16.60 increase for the CDHP member, it'll be $8.30. Take those dollar amounts and again, apply them to the retiree groups. Because on a percent basis, I believe the employees were seeing a little bit higher percentage increase than the retirees were. That table also is probably easier to explain and to implement because you're just taking that 50%. So when we do our technical adjustments to make sure that we have right down to the penny the correct rate tables, then we'll apply 50%. And then that's going forward. So regardless of what you do, you're looking at a increase in premiums to the members. But this ideally helps soften that blow. It's not ideal. I get it. I know from discussion, we talk about our lower paid employees and how it affects them. But it affects everybody to some degree. And it, you know, the cost of medical treatment, drugs, dental, whatever it is that an individual may need to access, those costs have gone up. And we're doing what we can to try to keep what has to come out of the employee's pocket to the minimum that we need to do and keep ourselves fiscally sound. Like I said, we will tap into catastrophic reserve if that's the direction the board would like to take. Going forward with all the ideas that have come up in the discussions, those are ideas we will come back with when we've had a chance to do further analysis and come back with some ideas on what that looks like. From the rates themselves, that has to be approved today because we've got to get them loaded and tested, and open enrollment is the 1st of May. That's only a month away. So we need to have this out there for everybody.
This is Betsy Aiello, but so the 50-50, it is coming from catastrophic reserves, right?
Yes.
Yeah, okay. You were just talking about if more came, but your recommendation is that there's enough in catastrophic reserves to hopefully be able to handle that. And then I guess in the budget bill to ask for backfill for next year.
So this is Celestina Glover. So in the catastrophic reserve, we have, this year it's 42 million. I believe it goes up to 48 million in the future plan year. This cost is going to be about 7.5 million based on projected enrollment in the plans and tiers. You know, that projection is fluid because we don't know if people are going to change plans or bring dependents onto the plan, things like that, new hires, people moving to retirement, whatever it is. So this is based on projected enrollment, so it is a moving number. This is our best, the best we can come up with the information we have today to say this is where we think we are. It is going to come from catastrophic reserve. And when we build the budget, we will get an updated memo. Siegel looks at our data and gives us a memo each year to tell us where our IBNR and catastrophic reserves need to be. And then we will build that into our budget moving forward.
Any other questions? What I'm hearing is we're trying to soften, Jack Raw for the record, I apologize. We're trying to soften the blow to the employee and keep the plan healthy and not dip into reserves that we would be in financial jeopardy if something were to occur, is what I've heard.
This is Celestina Glover for the record. That is correct.
Okay. Vice Chair Kelly.
Michelle Kelly for the record. I just want to put on record, thank you, Executive Officer Glover and staff for exploring these kind of, you know, the way the board can choose to subsidize our employees. I think I am supportive of your recommended rate mitigation measure, which was the 50%. And I agree with you that, you know, whenever I look at these things, I'm looking at how do we explain to employees what we're doing, but then for future board members, when we look back, how do we explain or how do they see and understand what we did? And I think that the 2025 solution, which is the 50% mitigation of the state premium, does that. It's easy to explain. I appreciate you saying it's also easier to implement because obviously we, you know, wherever possible, we want to make this easy to audit and to, you know, for the technical adjustments you talked about. So I'm supportive of the 50% premium and I appreciate all the work you guys did on this. Before I give up my mic though, I did have a request. that once we're finished voting on this item, I keep hearing that employees are having a hard time covering their out of cost expenses. And this year, the state legislature gave all employees HRA money. So, and I believe that is happening for the next plan year as well. And so can someone remind us how much those dollars are at today's meeting? And if possible, can you tell us, have employees used that money from their HRAs for the plan through to date, or can we get that information at a future meeting? Thank you.
This is Celestina Glover for the record. I did not bring that information with me for this board meeting, but I can bring it to a future one. We do know that some individuals are using their HRAs, and you are correct. We are funded by the legislature for plan year 2025. I can't off the top of my head remember what those dollar amounts are, but yes, we put in our newsletters and emails and such to let people know that the monies are out there. But for those plans that typically don't receive HRA money, that's probably a foreign language to a lot of them. So we keep trying to put the information out for members to access those funds as they become available. So we'll continue to do that. And we can bring you something back at the next board meeting.
Okay, thanks everyone for, I'm gonna ask one more question. Timing of our known pay raise that's coming up and timing of our premium shift. They coincide.
Celestina Glover, for the record, you're correct.
Yeah, I knew that. I just wanted it on the record because it would be catastrophic if it didn't line up. If you gave somebody a raise, then a month later, you took part of that raise away. Or if this went into effect right before the raise went into effect, it would have a financial impact on those individuals. I just wanted to assure that and have that on the record, so. All right.
Michelle Kelly for the record. Chair Rob, I just wanted to put some NSHE specific information out there because NSHE professional employees, which include our, both our faculty and our professionals, they do not get the pay raise until October 1st. So I don't, I don't think it can change any of our conversations here, but because the legislature didn't fund NSHE salaries, NSHE had to push that pay rise for professionals and for faculty, some of whom, earn less than classified employees. And I just wanted to correct that. So there is a large portion of employees out there who this will not line up for.
Thank you for clarifying that. That's why I wanted to put it on the record, make sure I wasn't off base, and it sounded like I was, including one portion of the people that are covered by this plan. Any other discussion before I call for a motion? Seeing none, does anybody have a motion?
Leslie Biddleston for the record. I move that we accept option number 3 as presented by staff, which is the 50% option. What's it called?
Premium mitigation.
Oh, 50% premium mitigation option.
Michelle Kelly for the record, second.
Okay, we have a motion and a second. Any further discussion? Seeing none, I'll call for the vote. All those in favor signify by saying aye.
Aye.
All those opposed? Motion passes unanimous. I do appreciate the full discussion. I do think we have some avenues to look at going forward. I do think they are important discussions and topics that we need to explore on how we set rates for all employees to get some parity and to not impact the lower employees or lower paid employees. And I do really want to explore, even though I know some individuals push to get that third option in there. I think the confusion and the migration between plans makes it extremely difficult. And that's why we find ourselves in these situations, making tough decisions like we just did. So appreciate everybody's time on the agenda item. We're gonna move on to agenda item number 8. Possible discussion and action of UMR's medical RX coupon program of Celestina Glover, Executive Officer, with possible action.
This is Celestina Glover. The report before you is a recommendation to not move forward with the medical RX coupon program. In discussions after the January board meeting, at which time this was approved, it was brought to our attention that there was some potential issues with this being a program we could utilize on all 3 plans. So the EPO and the PPO plans, we could apply this coupon program. However, the high deductible plan, those members would likely still be subject to meeting deductibles before they would be able to take advantage of this coupon program. I think that is probably still something that is being reviewed and considered on whether that is actually the case. It was also brought to our attention that this was a pilot program for some of UMR's clients and that they had come across some operational challenges. From my standpoint, and my recommendation, we require our members already to jump through a lot of hoops to access the various things, prior authorizations, co-pays, co-insurance, whatever it might be. There's a lot of discussion about what the cost of the plan is to members. And bringing in a program that potentially still has some bugs in it that need to be worked out, I just assume not put that on the plan or on our members. That's not to say that once the kinks aren't worked out of this, that we might not bring it back at a future date for a future plan year, but right now I don't think the timing is ideal for this program within PEB's offerings. With that, I'll take any questions.
Any questions? Seeing none, this does require action today. So do I have a motion?
Janelle Woodward, for the record, I make a motion that we accept Director Glover's recommendation to not go with that program of the, what do we call that? The medical RX coupon program and relook at it maybe down the road.
Okay, we have a motion.
Second, Betsy Strasburg.
There's a motion second. Any further discussion? Seeing none, I'll call for the vote. All those in favor signify by saying aye.
Aye.
All those opposed? Motion passes unanimous. We'll move on to agenda item number 9, appeals process. Celestina Glover, Executive Officer, informational for discussion.
So this is Celestina Glover for the record. There was a request at the last board meeting that we bring to the board a report that outlines the claims appeals process. And so this document gives you the information that was requested. So the appeals process is broken down in different areas. So a claim could be adjudicated and paid or not paid in a certain manner. The employee could then go back to UMR and say, hey, what's going on with this claim? I thought this benefit is covered. And sometimes it's just an error and they will go back and look at that, say, yep, you're right. And they'll re-adjudicate and they'll go ahead and pay the claim. That is not an appeal. That is just a customer service type inquiry. And those things can be internal as well. If we say something, someone's not eligible for a plan and then they come back and ask us additional questions and we respond to those questions, that does not rise to the level of a complaint or an appeal. It is really an inquiry. And we try to handle as many things as possible at that level to keep them from becoming appeals. Once the the person decides that they want to file an appeal, there is guidance and timeline. So level 1 claims appeals, that goes to, in this case, UMR, there are TPA. They will go back and gather the data, do the research, make the determination on whether their process was correct or the member's process was correct, or maybe some combination, and then take action accordingly. If the decision at that point is still negative to the member, then they have the ability to file a level 2 appeal. That comes to PEB. So PEB will go back and look at it. They'll work with UMR and they'll do the research to try to determine where the breakdown is. Is this something that we should have paid? Is our documentation accurate and easy to understand, or as clear as we can make it possible? Because nothing in medical seems to be easy to understand, but that our documentation is clear, that we put in those documents what our intent is as far as approving certain benefits and what we will or won't cover based on the plan that the individual is enrolled in. And then we respond to that level of appeal. And then in some cases, if they still don't like that decision, they can go to an external review. So that review is done outside of our agency and outside of UMR. And we have a third party look, and it's at PEB's cost. The member pays nothing for those external reviews. So they can go outside and say, okay, they'll gather all the records, look at medical records, whatever it is, whatever information they need, and they will make a determination on whether or not we should have covered it or not. We don't have a lot of external reviews, and of those that we have had, probably about 30% or so have been, our level 2 has been overturned by the external review. And then we go back and provide that information to UMR so that those claims can be paid at that time. The other piece of the whole process is the exceptions. When an exception is requested, there are some places where we cannot grant an exception in any way, shape, or form. If it is by law that something has to be done, I can't reverse that and say, well, yeah, the law says X, but I'll give you Y. So if the law says you have to do something a certain way, we cannot grant an exception in that case. In other areas, what we look at is, what is the intent of the plan? What do the documents say? What are our requirements legally and otherwise? And we try to determine where our documents were clear enough, or did the circumstances in that particular situation warrant an exception be granted? We do not grant a lot of exceptions. We do grant them in very specific cases. When we look at everything, the research is done. I go back and look at all the research that has been done, typically by our QC team, and make a determination at that point that yes, the situation warrants an exception, and then I will do so. If our documentation is clear, the plan benefits are outlined well, in those cases, no, I won't make that exception, because I can't say, well, Mary's exception is more important than Billy's, and they both have similar situations. So in those cases, when there isn't a valid reason to grant that exception, then we cannot administer the plan by exception. So we try to make our plan documents as clear as possible. Staff are trained to the best of our ability, so that if a question comes into our member services unit, they're giving out good information. If they want to take that up to the quality control team, they're giving out good information. And if we need to get somebody else involved because we're not certain, we now have our in-house legal counsel, and we'll take things there to make sure that we are on good ground, whether we're going to grant the exception or not grant the exception. So that's the process in a nutshell. There's a lot of detail in there. Statute dictates what we can and can't do, what our requirements are, and we follow those guidelines. And with that, I'll take any questions.
Any questions? Go ahead.
This is Betsy Aiello for the record. So we had a public, at the beginning, a public comment regarding a request for exception. It's my understanding that someone probably would have explained what was just explained to us as a board to the public that was requesting the exception, so they understood some of those limitations, or do you think not? Because sometimes that might help the outcome.
So this is Celestina Glover for the record. I went back and looked at how some of the memos were written back to the members, and there was a lot of information attached that maybe wasn't real helpful. And so we are in the process of revising those memos and letters to better explain to the member why the decision was made. That right now is an ongoing process. Our QC officer position recently became vacant, so I am helping in that arena. I've asked Brandy Mooneyham to actually assist with that, to make sure that what we're doing makes the most sense and we're providing the information back to those individuals. So we
Because
do
it
try to make
sounded
it
like
clear.
it could have been a communication issue as much as for understanding.
Yes, and it likely was. One of the things we are doing, especially in a more difficult situation or when trying to explain it in a letter isn't ideal or isn't clear, is to make a phone call to that individual and let them know the letter is coming and the outcome of that request, so that they maybe can ask more questions and hopefully staff can clarify what the reasons behind the decision.
Okay.
Betsy Strasburg, just some clarification for myself. Is the people who go through the exception process, can they or do they decide to go to the claims process afterwards if they're not getting anywhere? That's question number one.
This is Celestina Glover for the record. I think it depends on what the situation is. If it's actually a claims payment process, typically we refer them to UMR so that they can talk to the right people, because obviously we don't adjudicate the claims in-house. If it's something else, like we've had people request exceptions for being allowed to bring a spouse on the plan when they miss their deadlines for getting us the documentation, or even letting us know they got married in the first place. We have a 60-day window for that. So sometimes, it's pretty clear. We set a time frame and documentation required, and then somebody said, well, I got married 6 months ago. Can my spouse come on the plan? And without some qualifying life event that would qualify that to happen outside of that 60-day window, in those cases, those kind of exceptions typically aren't granted. There would have to be something real specific for us to go there.
Okay, and then my second question was on the 163 level 1 claims, and it went through all the levels in 2023. So by my calculation, that was about 58 claims through 1, 2, and 3 level that was overturned. That's about 36%. Is that kind of normal, or is that high or low?
This is Celestina Glover for the record. I think that's pretty normal. That's what I've seen over the years. Obviously, it would be probably a lot less if we just granted exceptions for everything, then nobody would file any kind of appeal. But yeah, that is pretty much what we've seen over the years.
Vice Chair Kelly.
Thank you, Chair Rob. I just have a question, I guess, around the exceptions to you've got it listed as exceptions to plan rules. I seem to recall that at some point during a board meeting, and I've watched these for too long. I've only been part of the board for 2 years, but I think there's a specific Attorney General's opinion that says the exception process can't be used to overturn plan rules made by the board. Is that, maybe I'm paraphrasing wrong, but I thought there was an AG's opinion out there. And the only reason I raised this is that you've listed it as exceptions to plan rules, but really it's not exceptions to plan rules because the plan rules are black and white and, you can't really make exceptions to those. What you're looking for is, or what exceptions I'm trying to understand when exceptions can be made, because it's more in the gray areas where there isn't a plan rule that supports or doesn't support a request, right? That where you can then look at supporting document to make an alternative decision. Can you explain that a bit better, maybe?
This is Celestina Glover for the record. You're correct. If the plan rules are very clear, such as the 60 days to bring a new spouse onto the plan, then no, I can't grant that exception. It's where the plan rules maybe are a little murky and it's not that the plan rule is murky, it's that how it's explained in our documents, if it's not clear in there that something can or cannot be done, then we have to look at those and go, okay, our intent was this, but it's not clear in the documentation. And in this case, yes, we may need to approve that exception. That does not happen very often. And if the plan rules say, you have to do step 1, 2, and 3, I'm not going to grant an exception to step 2 because somebody asked for it because they don't want to do with that step or they don't agree. If that has been approved in our plan design, in our plan documents, and it's clear. But if we somehow miss putting that information in the document so it's not clear, that's when we have to look at, does the situation warrant an exception? And in that case, that's when I will have to make that decision.
Great, thank you. And then I just have a follow-up regarding, so I guess all of the levels of appeal. I did the statistics as well, and I see level 1 claims, basically 28% were overturned. When it comes to staff, you're only overturning 19% of those submitted. And then when it's going to the external review, they've approved 30% of the requests. So I'm kind of interested in the essence of continual improvement. When does PEB staff kind of review these appeals in aggregate kind of a few times a year to see if there's any learnings and improve the plan document or change the procedure to cut down on a particular issue, like if there's trends coming out through these appeals? That's for stage 1 and 2. And then specifically for stage 3, I'm surprised at 30% overturn rate. And so I'm wondering, what kind of supporting documentation or explanation, I guess, does the external review body give to PEB to kind of justify that 30% review? And then once again, for continual improvement, what do you do with that information?
So this is Celestina Glover for the record. We do review internally what those appeals are and what they're doing. So for us, it's typically going to be level 2 and external reviews. But we work with our vendors, so in this case, UMR, if it's a claims issue, to determine, why are we getting the number of claims we're getting, are they all in a specific arena? So yes, that's looked at. If it's related to how our documents are worded, or is it difficult to find the information in the documents? Recently, myself and our legal counsel have been looking at our master plan documents to determine, can they be formatted in a different manner? And where can we make the language more clear so it's easier for people to navigate through the documents and understand what is allowed and what isn't? And that is driven by when we hear public comment, when we get level 1 and 2 appeals, external reviews, all of the different processes, including requests for an exception to a plan rule. Do we need to change the plan rules? Is that something we bring back to the board? for future plan years. So yes, we do look at all of that to make a determination. As far as the external reviews, those reviews, a lot of times, some recent requests for reviews that I have seen, it's because the plan doesn't cover a certain medical procedure, for one reason or another, could be considered experimental or not proven. But the medical provider and the member still believes that that treatment should be done. And so they have the right to make an appeal to an external review. And then the organization that does that review will gather all the medical records. They will look at what is considered experimental, not experimental, where they think we should go, and they'll make the decision to uphold our initial decision or to overturn it. And that's obviously case by case.
Okay.
Thank you.
Any further discussion? Seeing none, we will close agenda item number 9 and move on to agenda item number 10. Public comment may be taken during this item. Comments may be limited to 3 minutes per person at discretion of the chairperson. In Carson City.
Kent Urban, Nevada Faculty Alliance. So thank you for mitigating the employee premium increases. No increase for employees is ideal, but we appreciate that you softened the blow today. We will continue to advocate with the legislature for stable benefits and stable employee premiums. Today's discussion went well beyond next year's rates. We would welcome a strategic discussion about the premium structure. A first way to address entry-level employees is to go to 100% coverage of the premiums for the employee-only tier of a base plan, as most of our local governments do for their employees. NFA has suggested income-adjusted premiums in the past and been rebuffed at that idea, so we do welcome that discussion. Regarding migration among the 3 plans, we did advocate for having this middle option. It has only been in existence for several years, so migration is likely to stabilize over a few years over time. A problem leading to confusion is that a deductible was added to the HMO EPO plan, and the middle low deductible plan was converted to a 0 deductible plan. And those issues of the differentiation of the 3 plans need to be addressed. On another topic, RIMSA and Carson Tahoe are monopoly or dominant providers in their localities, and they really must be in network for state employees, however that gets accomplished. Next, the executive officer report indicated that the quality control officer position is vacant. That's a very important position for PEB. It's specified in statute 287.0426. The director of the Department of Administration, Chair Robb, appoints the QCO and defines their duties with the concurrence of the board. So that's different than the other executive staff at PEB. The reporting line is special because the QCO should be able to report fiscal issues directly to the chair and the board without interference by the executive administrator. There was that's not a problem now, but there was a notorious case in the 1990s where the board or committee wasn't being informed of serious deficits. And that's really where that position and it being in statute came from. In the past, the QCO served as the contracts and procurements officer. They also played a participant service role, basically as an ombudsperson. Recently, it seemed that it shifted to a strictly compliance role. So now with the vacancy, it would be a really good time to look at the job description and figure out what's best for the plan and the board and the participants. Finally, please excuse my skepticism about mid-year projections of reserves. We have a dozen-year history of projections being way off, mostly leading to excess reserves. Of course, this could be the year when that reverses, but we won't know until the close of the fiscal year. So thank you for the opportunity to comment.
Thank you. Any other public comment in Carson City? Seeing none, do we have public comment online?
We have one online right now. One moment, please. Douglas Unger. Please
Hi.
slowly spell and state your name for the record.
Doug Unger, D-O-U-G, UNGER, Nevada Faculty Alliance. I also would like to thank the board for approving the 50% mitigation for employee premiums. And I understand that it's not the most desirable outcome, but it's the best possible outcome for this coming plan year. I would like to speak up for the PPO plan, which is so new that employees are just getting adjusted to it. And I think the movement back and forth between plans is as state employees are trying it out. We really needed, as do most other states, and I could say all other university systems in the region, we needed that third plan as a copay option to balance out the CDHP and the HMO plans that were available. The actuaries reported that Nevada is unusual in that it has a high CDHP enrollment. The reason it's high is because of the dire physician and provider shortage in the state, and the fact that the CDHP offers opportunities, ample opportunities to travel out of state to seek necessary medical care. Please note that there's an article in the current Nevada Current about the Nevada Board of Medical Examiners being one of the impediments to physician and provider access in our state because of its draconian practice in over-regulating physicians in order to basically defend physician turf and income. It seems to me that this would be a good opportunity for Director Robb and the board to recommend to Governor Lombardo that he should look into reforming the practices of the Nevada Board of Medical Examiners in order to mitigate the physician shortage in the state. We are 45th of all the states in our access and quality of medical care. In conclusion, I would like to welcome Director Robb's suggestion that it might be possible to look to an income percentage tiered premium scale. The Nevada Faculty Alliance has looked into this. I would refer the board to a report that I made to the Nevada Board of Regents in January of 2019, which examined higher education plans. And I pointed out that the University of New Mexico plan has a tiered premium scale, which is different than the university systems of other states. It's fairly high cost for the high income employees, but it's very low cost for the low income employees. But the difference is that the University of New Mexico has a medical school clinic-based HMO option that's very low cost and provides a kind of relief valve for high premiums for those who perhaps in the upper income tiers who really also can't afford it. So we're way behind other states in our provider base. I've hoped that our UNLV and UNR medical schools can grow their clinical practices to be able to offer a state-based clinical practice HMO. Until that happens, I think the tiered income proposal, at least for higher education employees, is going to be an issue. In conclusion, I think the overall position we should take is that the state should raise its contributions per employee back to the 93% level. There really is only a difference of the price of a fast food hamburger between what the state paid in 2013 per employee and what it's contributing per employee this year. And there's been lots of inflation over the past 11 years. If we could get the 93% contribution, that would provide, that would more than take care of the rate increases that you voted on today, plus supply about $4 to $5 million extra into PEB's budget to take care of medical inflation over the next biennium. Thank you very much for everything you do. I appreciate, and we appreciate everyone on this board. And thank you very much. And thank you to Executive Officer Glover for maintaining the healthcare advocates meetings which are so extremely helpful for us to be able to explain to our members and to employees what's going on with the PEB plan. Thank you so much.
Okay, thank you.
Chair Rob, that is all. Public comment.
Seeing no more public comment in Carson or online, we will close public comment. We'll go on to item number 11 and we will stand in adjournment. Thank you.